with a little quiz. Let's say you get an EKG, say ER. Someone comes in complaining of shortness of breath or chest discomfort. Let's say they just have some chest discomfort, chest pain that's just kind of hard for them to articulate. And so you examine them and you find that their heart sounds are kind of soft. You can't really hear them very well. And you go ahead and get an EKG while you're waiting for the chest X-ray. The lungs are clear. And what you find on the EKG is that all of the QRSs are no more than 3 millimeters high or deep. They're just tiny everywhere on all 12 leads. What do you think? What? Cardiac what? Tamponade. Well, okay, so it is fluid in the pericardial sac that's causing this resistance to electricity. So all the QRSs are really tiny. Tamponade is a physiologic term rather than a, well, it's never an EKG term, but it's a physiologic term that means that the heart has so much fluid around it that it can't fill. You have a filling problem. So it's a physiologic problem. But you can have a lot of fluid in that pericardial sac with no tamponade, no real physiologic problems. And that is a tip-off if you have real tiny QRSs in it. Good. That's not on the exam. What do we got? It's not in the book either. I just noticed last night. It's not in the book either. All right, so any questions before we get started? All right. Kendall Carter, number 61. Huh?
For the rhythm, I got sinus rhythm, heart rate of 75, PR of 0.2, QRS of 0.08, QT of 0.32. I got a normal access of plus 75. And then I put a first degree AV block. I found QAs in B1 through B4, so I call that acute anteroseptal infarct. And we saw inverted T-waves in AVL B5, so we thought that could be lateral ischemia.
Lateral what?
Ischemia.
Okay. Any corrections or additions? Did anyone simply call this anterolateral injury instead of infarct? Everyone called it an infarct? It looks a lot like an infarct. On the other hand, in V1, V2, sometimes you see almost a little tiny R wave there. I think probably the electrocardiogram machines are going to call this an infarct. Some purists might argue that there's a little bit of an R wave there because it's just injury pattern, but I think calling this an infarct is reasonable. Anything else? Shannon? 62?
Oh, sorry. I just started talking. So I got regular sinus rhythm with a heart rate of 75, a PR of 6.16, a QRS of 0.08, a QC of 0.44, a left axis deviation, and I got anterolateral ischemia and LVH. And possibly
Possible prolonged QT. Anyone find anything else? Yeah.
CACs.
What?
A premature atrial contraction.
PAC, the third beat in 1, 2, and 3. Is that what you're seeing? So let's look at that third beat in 1, 2, and 3. Look at specifically lead 2. So if you look at the rest of the EKG, that beat comes a little early, right? And it has a P wave in front of it. And so that would be a premature atrial contraction, she said. But let's look at the PR interval in lead 2. What is the PR interval in lead 2 in that third beat?
Talking about this one? The fourth?
Yeah.
Oh, okay.
Is it less than 0.12? No? It's real close. It's real close.
Is it 0.111?
It's a lot closer. Look at the PR interval in the third beat and compare that PR interval to the second beat. It's 0.12 in the third beat. It's 0.16 in the second beat, right? You can just look at that PR interval in the third beat and tell it's different. And as she points out, it comes early. Look at the first beat, the first PQRS in lead 3. See how that QRS, that R wave, looks a little funny on the front end? That PR is really short, and there's a delta wave there. Do you see the delta wave in that first beat? So this is probably a patient that most of the time is in a normal sinus rhythm and has anterolateral ischemic changes across the precordium, but probably also has pre-excitation syndrome. They're in and out of it. They're in and out of the pre-excitation. They're in and out of that fast track around the AV node. This is a really tricky one. You wouldn't have anything this subtle on an EKG exam, but pointing out that that third beat is a little early is the tip-off to begin to investigate this a little more carefully. Anything else on this EKG? Yeah.
Sorry, premature atrial contraction is different from pre-excitation syndrome if it only happens in one of the beats.
Well, so yeah, they are different in terms of EKG diagnoses, you know. But here on the third beat, what you have is both. You have a PR interval that's really short, and so they're in the fast track, but it comes early. So they're in the pre-excitation syndrome and it came early.
Okay.
So it's both. Yes?
We call it anterolateral injury instead of ischemia.
Yeah, you can certainly call that injury. It looks like injury better. In fact, I did call it injury. I called it anterolateral injury. Anything else? 63, Bailey?
Okay, I got sinus rhythm, heart rate of 95. Well, I put a line through the PR because I couldn't find one, so I don't know why I put sinus rhythm.
Couldn't find the PR. Okay, keep going.
And then QRS 0.08, QT, I also put a line through it. Pattern of tracing, put Q waves in 2, 3 AVF question mark and maybe in B1 through B4. And I put anteroseptal infarction as a Q and then inferior infarction
Right.
as a Q.
So there are two infarcts here, the anteroseptal area and the inferior area. Okay?
Oh, and my axis was LED negative 70.
Left axis deviation.
Yeah.
Okay, so you couldn't find P waves, couldn't do a PR. So are there P waves on this EKG? No. So, what's this rhythm? Is it regular?
No, it's irregularly.
Is it really irregular? Irregularly irregular? Looks pretty regular to me. So, if you don't have any P waves, and the QRS is not wide, and the response, the ventricular response is regular, where's the pacemaker? Remember, there are three places for a pacemaker to be. Sinoatrial node. Where's the next place? AV node. Where's the next place? Ventricle. It's hitting hard. Where's this one?
They're confused because their rate was.
What's tripping you up is the rate's too fast?
Right.
Would it be like AV node tachycardia?
That's exactly what it is.
Accelerated.
AV node tachycardia. Okay, so remember, the only three places the pacemaker can be if it's a natural pacemaker: the sinoatrial node, the AV node, or the ventricle. Well, that's not exactly true. I mean, it can come anywhere from the atrium. Sometimes you have some atrial beats, but there'll be P waves associated with them, okay? Even though they're not coming from the SA node. But you've got an atrial pacemaker, you've got an AV pacemaker, and you've got a ventricle pacemaker. And normally, the AV nodal pacemaker is what rate? 40 to 60. The ventricle, 20 to 40. The sinoatrial node, 40 to 100. Well, this one is coming from the node, and we know that because there are no P waves. It's regular, and the QRS is not, it's narrow, it's not wide. If it was coming from the ventricle, the QRS would be wide. So it's too fast for a node, so it's nodal tachycardia. There are lots of terms for this. It's really AV nodal tachycardia. It can also be thought of as someone here to see you call. Can also be thought. It can also be called idioventricular tachycardia. I wouldn't write that down. I'd just say it's AV nodal tachycardia. Okay.
You said it's not SA node because there's no P's, is that what you said?
Right.
Okay.
Hello? Yes. Oh, yes? 36.
34. 34.
Okay, all right. Okay. Thank you. It was God. And she was asking me if you all did your homework. Okay. And how many of you are 34 with two ghosts?
Yes.
Other questions about this one?
So I want you guys to tell me, why is the baseline wavy? Could be agitation or movement. Sometimes your patients that come in with pain are going to have a hard time holding still. So you were still able to read that. Very good.
So what's the answer to the question?
What was the question?
What is the difference in diagnosis of primary two-way fractures?
Oh, the question on paper.
What is the differential diagnosis of T-wave change?
Ischemia.
Ischemia. What else? You have to speak up, I can't hear you.
If they're peaky, it could be their potassium level,
Potassium levels can be higher or low.
magnesium levels,
Magnesium levels can be higher or low.
Ischemia.
pericarditis.
Pericarditis, inflammation of the epicardial surface. Heart attack. What?
Increasing ICP, intracranial pressure.
Increase in cranial pressure. 64. Sarah?
So this one, it was a regular rhythm, second heart rate between 180 and 250, with a PR of 0.12, QRS of 0.08, QT of 0.2, but I got a normal axis of 70. And I didn't really know what to call it.
Okay, so go back and look at, is this one regular? No. Is it regularly irregular?
What?
That's what they said.
Okay, so maybe you're not seeing P waves. Maybe you're seeing something on the, so go back and study this carefully and look to see if there's a P wave before each QRS.
No.
There's not. So it's an irregular, very, very fast rhythm with no P waves. So what's the rhythm? AFib. And because the ventricular response is greater than 100, we call it rapid ventricular response. Atrial fibrillation with a rapid ventricular response. So let's go over that again. The patients in atrial fibrillation, the atria are not contracting, they're just quivering like this, but the electricity is periodically getting through the AV node. This is not bypassing the AV node, it's going through the AV node. It's just going through too fast. What's the problem with the patient's stability? Why might the patient develop instability in this rhythm? Your heart's, the ventricle's beating too fast, therefore it can't fill, so your cardiac output might fall. Your cardiac output may go down, you may become hypotensive, lose consciousness. So we have to slow down the AV node. How do we do that? What drug? Calcium channel blocker. Calcium channel blockers slow down the AV node. There are lots of things we could use, but the drug of choice in this instance is a calcium channel blocker. I don't know which one. I guess the one your wife has, or your husband has stock in. Okay. That would be Scott Pruitt that would do that. Olivia Langley,
Okay.
65.
For the rhythm, put sinus, rate of 80, PR 0.16, QRS 0.08. The QT, I got 0.36 in lead 3. I think is really the only one I could find, a T wave. And then the axis, I got normal at 60 degrees. And I saw primary T wave changes in V1 through V6, so I called that anterolateral ischemia, and then also right atrial enlargement because of the big P waves in lead 2. And that's it.
Anything else? Any questions on that? 66. Michelle.
I got a sinus rhythm rate of 100, PR 0.08, QRS 0.04, QT 0.36 with a normal axis. I got right atrial enlargement in the inferior leads and pre-excitation syndrome because of the short PR interval.
What was the last thing?
Pre-excitation syndrome.
What's the PR?
I got 0.08.
Lead 3.
Does look a little short, a couple of those leads.
Yeah.
Might be a pre-excitation syndrome. I didn't call it, but PRs are pretty short in lead 2. I don't think there's a right atrial enlargement. I think that the P waves are pretty prominent in 2, 3.5. They're kind of sharp, but they're not very high. They're not as high as a third of the QRS, so I'd probably not step out and call that. Otherwise, I think that's it's a good call. I would only match up pre-excitation with my PR interval. If you call the PR interval shorter than 0.12, I'd call it. If you didn't, I wouldn't call it. The machine, as we noticed earlier, or told you earlier, the machine's going to measure that PR interval. It's going to measure it more carefully than you will if you don't have calipers, and it'll average. So sometimes the machine will miss a pre-excitation syndrome because it's averaging PR intervals. They would have missed it on that other one we had a while ago where the patient was in and out of it. Good. 67. Kristen Nelson.
She's not here.
Not here. Would someone call her and see if she can read this one? DM?
Oh,
Caitlin Spurrier.
She's here.
yay.
I'm not here. She's here.
So, for them, I was really confused because I thought it was a ventricular pacemaker.
It is.
Okay.
End of conversation.
That's all I thought.
That's all you can do. If there's a ventricular pacemaker, there's a spike, then it takes away all the intervals, takes away, the axis, takes away ischemia. So that's really the only reading you can give this, is ventricular pacemaker. Does anyone have questions about whether or not this is a ventricular pacemaker?
How do you know it's in the ventricle? What chamber? Yeah.
Like, I don't, because it looks like to me,
Because-
that's almost like a P that gives extra thing on a P and then leads into QRS. Does that make sense?
Well, I guess, I'm not sure what you're talking about, P's, but
P.
there is a,
Then
are you talking, P as in
P-wave?
pony?
Yeah.
So the spike is right there
Uh-huh.
and right there. It's up and down. And the thing that follows it is a ventricular S wave.
Uh-huh.
So it's causing the ventricle to contract.
Okay.
It's sitting right on the ventricle.
Okay.
There's no atrial contraction. Yeah.
So if it's in the ventricle and it usually fires at 40, is there anything wrong with it?
Oh, no, it's a ventricular pacemaker. So it has a battery in it, and we can set it
Okay.
to fire from 40 to 100.
Okay.
So they've set it to fire at whatever rate this is. They usually set it around 70, 72. What is this rate?
85.
85?
So anytime you see those pacemaker spikes, it's an external pacemaker that we placed internally. And she just specified that it was ventricular pacemaker, which was great. You're not going to have to differentiate in
Which
clinical
ventricular?
situations, whether it's a single ventricular or biventricular. You're not going to have to differentiate any of that. Just know that you're not going to be able to read much of anything in EKGs when they've got a pacemaker. That's why back in the day, we used to put a magnet and stop it so that we could see what the EKG was showing. I don't know if they still do that. I've been out of the ER since 2012, so that's quite a bit of a lag.
They also have pacemakers now that are atrial and ventricular. So they'll fire both the atrium and the ventricle sometimes. Okay, 68. Paul's here. I slept well this morning.
Alright, I got sinus rhythm, heart rate 105, so sinus tachy, PR 0.12, PRS 0.04, QT 0.24, And on this axis, I got RAV at negative 120. And then other than that,
I
I
mean
got,
plus 120.
oh yeah, sorry, plus 120, yeah. And then an old anterolateral infarct.
Anything different?
Left atrial.
Sinus, I guess sinus tachycardia,
Yeah.
right axis deviation, sinus tachycardia, and an old ventrolateral.
Morgan, say what you were gonna say. Just
Oh,
what you were
left
gonna say.
atrial enlargement?
Sorry?
Left atrial enlargement? Maybe?
Okay, so I think, so you're loving this atrial enlargement. You're loving it a lot. Yeah. Maybe you're loving it a lot because there's only one thing you have to look at. P wave in V1, P wave in lead 2. But we're overcalling left atrial enlargement a little bit because you're tending to call it every time you see a biphasic P wave. Okay? But I think the criteria by Marriott at least is that this terminal portion needs to be one small box deep and one small box tall. It needs to be pretty big to call it left atrial enlargement on an EKG. It wouldn't be wrong to call this because it's biphasic, but the patient doesn't have any clinical findings or symptoms that would make you wonder about a large left atrium. Of course, you could, with an old anterolateral infarct, you could have left ventricular failure and a large left atrium.
I thought this one acute, I thought it went
Those are almost
with
coming.
the time.
Oh, the acute infarct you
Yeah.
thought, instead of old?
Yeah. I didn't think it came.
Well, in lead V3, and lead V4, and lead V, I mean, yeah, 3, 4, and 5, I think the ST segment is a little bit convex. So either reading would be reasonable here.
Yeah, it's 4 and 5 is more acute.
Yeah. I agree with that. It's a little more convex. But we're not gonna worry about that, right? The important thing is to figure out if there's an infarct here. 69. Ryan?
Sinus rhythm, heart rate 90, PR 0.12, QRS 0.08, positive 60. I had an age indeterminate infarct and I did not write where, so, oh, it looks like inferior. And T-wave changes possibly in lead 2.
Q-wave changes where?
In lead 2, just because it wasn't a Q-wave there.
Did you call it inferior infarct?
I did.
Yeah. So that's why the T-waves are
Right.
present there. So what's the age of this infarct?
I put indeterminate.
Indeterminate? So you could call it age indeterminate? Probably is, because the ST segments are flat on the baseline. Did anyone get left axis on this?
Yes.
I would recheck your arrows on the axis. I think lead AVF is probably negative.
Oh, yep, sure it is.
Just a
Actually,
little bit.
I tried something different on this one. I tried something a little different on this one, thanks to Zach, actually. This is
What, the
I was asking you
vectors?
about, yeah.
That's a tail, man.
Yeah, so like say on like AVF there,
Yeah.
what do you read on that? What do you?
I would say that so you have to know where to put your baseline.
Right.
And I would say that it goes up maybe 2 boxes and down maybe in that second one, 3 or 4 boxes.
Yeah.
So it's a little more negative than positive. It's not really, it's not
Yeah.
really
Doesn't cancel itself
it's
out.
a little bit more.
Right.
So if 1 is going out here and F is going up here, you probably got something in that quadrant. And so you look at lead 3 puts you up here as well,
Yeah.
right? So that shoves you up probably above -30.
Okay. Yeah, this is probably the toughest to access to that book.
Other questions
Sorry.
about
I know,
69?
right? Thanks, Dennis.
When
So
the
the
call
quick,
is after the
the
same.
quick and dirty axis test is to look at 1 ABF. And if 1 is up and F is down, then you have to look more carefully and make sure this is probably in the left, left upper quadrant. Okay. When do you have to look more carefully to make sure this is not right axis deviation? What's the tip off when you first look at the EKG that you've probably got a right axis deviation? 1 is down. So if you look at 1, 2, 3, and F and they're all up, we know it's a normal axis, right? You're beginning to get these patterns. Are you beginning to understand that you can interpret a 12-lead EKG 80% of the time, 90% accurately, 80% of the EKGs, 90% of the time accurately, without really understanding very much about cardiac electrophysiology? Okay? This is the same phenomenon. This is exactly the same phenomenon that you can practice dermatology 80% of the patients, 90% with 90% accuracy with a 15-second examination. All you have to do is have their clothes on. Look at it and know what it is. It's called pattern recognition. And these patterns become developed with practice. Patterns become developed with experience. And dermatologists get a bad rap because they don't spend any time with their patients. They're less interested in the story than in what this thing looks like, because they know what's wrong when they just glance at it 90% of the time. Sometimes they don't know what it is and have to biopsy it and take a more detailed history and so forth. My wife, who died in 2009, was a standardized patient for 25 years over at the medical school, and she was really good at delivering the illness script, and she was really good at watching students and giving them feedback about how they took the history. So she was really critical when she went to the doctor. She was really critical at how well they interacted interpersonally and how well they took a history. She fired 2 dermatologists before I slowed her down. Before I slowed her down and said, you know, both of those people you fired were really good. They knew what was going on. Yeah, they didn't talk to me though. They didn't listen to me. So, I don't know. They're not much on listening.
She's the one that taught Dr. Vanetta to take a look at himself in the mirror.
Oh my.
Humanities and.
But one of the things we train these you haven't seen the standardized patients yet. We have. Did the standardized patients give you feedback?
Yes.
They're pretty good at it. They're pretty good observers. We've trained them really well. They're good observers, and then they give you feedback. Probably 5, 6 years after my wife had been doing this, and she was doing a really good job. I came home from work one day, and for some reason, about some issue, we got into a fight. And we're standing in the kitchen, I remember very carefully. And we're standing in the kitchen, and we get in this argument, and it begins to ramp up very, very fast. She's on the attack, and I'm on the defensive, and I'm pretty good at being on the defensive, and I mean, it's getting loud, and it's kind of scary because this didn't happen very often in our marriage. And so I decided to ramp up the volume to see if I could overcome this bear coming at me. And what she did was say, Jerry, you want some feedback? Game over. Handcuffs on. Okay.
That's funny.
Did we do 69?
Yes.
All right. Audrey.
All right.
got a sinus rhythm, heart rate of 65, PR of 0.20, QRS of 0.16, QT, I didn't do it, I'll do it. 0.40, and then the means QRS axis, I got plus 100, so RAD. I got a right bundle branch block, first degree AD block, and then RAD for my conclusions.
Anything else? Right axis deviation, right bundle branch block, first degree block. Excellent. I'm sorry?
I get it. I have that on the line notes.
Yeah, I got it.
Lead two. Okay, so look at lead two, and she's saying that that ST segment is kind of slurred a little bit. I commonly say that it looks like someone's kind of put their finger up against it and smeared it down. So it's a nice pickup. Number one, well, digitalis is uncommonly used in today's medicine. It's still used occasionally in people with severe congestive heart failure, but not very often. It wouldn't be something you'd call an EKG. You'd wonder, some people might, if they're older than me, they might say there's a digifect. But this is probably not a digifect. This is probably ST segment and T wave responding to the right bundle branch block. The ST T wave is supposed to be opposite the last portion of the QRS. So that's probably what's happening there. It's even more slurry in lead 3 and F, but that's because of the bundle branch block instead of digitalis. Anything else on 7? See, I mean, it took us 2 hours to get through these the first week. It's taken us 35 minutes. Keep flying through it. Yeah.